so many of you are on. We are so excited to start this webinar series. Make sure you log in every month. There'll be a different one every month with multidisciplinary speakers from all over the world. So this is a really beautiful collaboration between a few different groups. So of course, everyone on here knows the Congenital Heart Academy. And then just as a little introduction, CNOC, the Cardiac Neurodevelopmental Outcome Collaborative. It's a multidisciplinary international collaborative of clinicians, researchers, families, parents, and we're all working together to try to address the challenges of children with congenital heart disease, especially the neurodevelopmental outcomes that affect them on a day-to-day basis. CNNN, or the Cardiac Newborn Neuroprotective Network, is a special interest group that is directly collaborating with Congenital Heart Academy to put this together, and specifically works on improving the care of infants with congenital heart disease, and it was founded and led by Dr. Sam Butler. And then finally, PCICS, the Pediatric Cardiac Intensive Care Society. They are also collaborating in this. It's also an international multidisciplinary collaboration, and it is dedicated to improving care for critically ill patients with congenital heart disease, which includes their neurodevelopmental outcomes. Here's some information. If you want to learn more, follow us on social media, and you can go to the websites for more information. All right, should we get started? All right, let's do it. So our first speaker, I don't know that he actually needs any introduction, but I'll go for it. So Dr. Gil Wernovsky, he is a world-renowned pediatric cardiologist and intensivist. He's currently, for a little bit longer, at Children's National in Washington, D.C., and he was a founding member of PCICS, CNOC, and Congenital Heart Academy. So he is truly one of the founders of this whole thing. So thank you, Gil.
Thanks, Chetna. My former colleague, Tom Spray, used to say that once you start giving the history talks, you have one foot in the grave. And I really do appreciate the title, How Did We Get Here? I'm going to change it so that I feel a little bit more alive. For the people that are new to the Congenital Heart Academy, in March of the pandemic, when everything sort of shut down, we started thinking of ways to continue to educate our fellows, and it sort of ramped up pretty quickly. And then I spoke with Sasha Agati, cardiac surgeon in Sicily, and Grace, who's a cardiac intensivist, originally from Brazil, but now in Qatar, about sort of doing a free platform. We learned about Zoom, and we thought it was a good idea. And over the coming couple of years, I think, Grace, what do we have? 35,000 unique people that have joined over time from 107 countries.
Yes.
And
yes, basically from all around the world, you have almost 15,000 subscribers on YouTube channel, and more than, I think, almost 30,000 different people that connected with Congenital Heart Academy.
It's been an overwhelming success, certainly nothing that I think any of us anticipated at the very beginning. And I think one of the things we're most proud of is the members are from every type of subdiscipline that touches children with congenital heart disease. And I think part of what the CNNN and Chetna and others have done is create a 6-part series that really reflects our membership and reflects what these babies need, from diagnostics to the people at the bedside to the people that follow them later. Because this is the cardiac I want to be sure I get this right, Chetna, the Cardiac Newborn Neuroprotective Network, we're going to be focusing specifically on that segment of CNOC, which are the newborns, which are the ones and their parents who probably need the most amount of support through this journey. And this lecture series will include things that are relevant to those who care specifically for newborns. There's much to be learned in the outpatient department. There's much to be learned in long-term follow-up. There's much to be learned in the fetal realm. But again, much of what we're going to be talking about here is relevant to those of us who touch these patients and their families in the intensive care unit. And I think we'll be talking toward the end about the coming series, but it includes neuromonitoring, neuroprotection, neuroimaging, how to safely handle babies, how to safely feed babies, the questions that come up on rounds, or they should come up on rounds, all the time. And the experts who have pushed this forward are, as you can see, in this panel, and they'll answer your questions as we move along. So without further ado, I am going to go to this, and I think do I need to swap displays? I can't tell which one is up.
No, it's good.
I'm good to go? Okay.
Yes.
So as you could see that I'm really excited to be here with Bea and Kelly, and I'm not going to say very much historically. What I'm going to do is go through these slides relatively quickly, especially the references, because you can go back to YouTube where you can take a screenshot if you'd like them. So I apologize for going quickly, but this isn't like sitting in a lecture hall where you don't get anything following this. You can go on YouTube and go on this and stop the screen and see any of the lectures that you would like. So how did we get, so, as I'm approaching retirement and getting older and whatnot, how did we get here? More like, where the hell are we? Where is the field right now? That's where I'm going to try to get to as we move forward into the next sort of decade or two, that we will charge all the people on this call to improve things for our babies. So I'm going to do a timeline of what we have learned over the years. Starting with the earliest descriptions of congenital heart disease, we not only describe the patients, but we describe some of the phenotype, what they look like as kids and as young adults. We're beginning to start to describe the families. This lagged a long, long time behind describing the patients. And we describe the risk factors. And much of that I'll be going into very quickly. But where we're going, I think, is to not only study the kids who are having problems, but as Tom Glenn and others have done recently, describe what are the resiliency factors. These aren't the opposite of the risk factors. These are things that you can do to improve outcomes for kids. And then what I hope that we can start to move into in the next decade is interventions for the family, interventions in the fetus. And then this series focusing in on interventions in the intensive care unit. Here are the current titles of the sessions. These will probably tweak a little bit as we move forward. If you've registered for this one, you've registered for all of them. So you'll be getting a link as we move forward. All right, here comes the old guy history stuff. So starting early on, what could the surgeons do? They could do things through a thoracotomy, which was limited to shunts and bands and coarctations. So we may be able to see some 60-year-olds now with those things that have been done. But the first disruptive change was cardiopulmonary bypass in the mid-50s, allowed us to get into children's hearts with ASDs, VSDs, tetralogy, AV canal. The first interventional cath was in 1966. That opened us to transposition and some of the early attempts at total anomalous pulmonary venous return. Portable echocardiography came around in the sort of mid to late 70s, but the real disruptor was the prostaglandin. Prostaglandin was used in trials in the late 70s, was approved by the FDA in 1981. So if you were born before 1981 with duct-dependent heart disease, which is most of the neonates that we're talking about today, you did not survive. That also translates into nobody is really over 40 yet with complex congenital heart disease. This opened the door to neonatal heart surgery. You can see arch repairs, Norwood switches, et cetera. Interventional cath then became an entity, again in the 1980s. And I think we underestimate the overwhelming thing we take for granted. We were talking before we got on about what are we going to do now that TikTok is gone. But the ability to have communication across centers. Prior to the internet and World Wide Web and the WWW that we're all used to, which came about in 1993, it's not that long ago. I was already in attending for about 5 years, working on paper at that point. And it was around that time, before the World Wide Web, that the Boston Circulatory Arrest Study for transposition came up. For those of you who don't know the Pediatric Heart Network, it is a wonderful funded group from the National Institutes of Health here in the United States, and that then funded the single ventricle reconstruction trial. These two trials were the pivotal trials that were cohort studies to look at patients that had newborn heart surgery, transposition and hypoplastic left heart syndrome. And now the Boston Circulatory Arrest Study has 40 years of follow-up, and the single ventricle reconstruction trial close to 20. The fact that we're now collaborating, many people on this call will take for granted. But prior to the mid-90s, we were in competition with each other. My center is better than your center. We have a better paper than you do. Fortunately, that, although still present, is not nearly what we had before. What we described prior to prostaglandin is that the brain, the only problem we saw with the brain was stroke and brain abscess. The kids didn't survive, and there were no neonatal operations. As the children got a little older from those early neonatal operations in the 80s was the recognition that some kids were having some difficulty. And that was the first impetus to study this in an interdisciplinary way. And by about 2005, the full spectrum of disabilities that are age dependent, and you're going to hear about today, came out. Similarly, there's the etiology of simple versus complex came about. But at the beginning, it must be the surgery. That must be the problem here, right? Which is what led to the deep hypothermic circulatory arrest trial. I am not going to go through this paper. What I will tell you is we enrolled 191 patients, 180 consented, 168 survived, which was the original cohort. And believe it or not, and this is a tribute to the follow-up team, 100 of these patients are still being followed. 100 patients followed, over 50%, 30 years out. It's truly remarkable. This was our group a long time ago. I am so thankful for the mentoring I received from Jane Newberger and Dave Bellinger and Richard Jonas in this time. I am not going to go through this. You can look at these on YouTube, 45 minutes at a variety of studies. As we followed these kids longer, looked at this nonlinear relationship of deep hypothermic circulatory arrest, IQ, fine motor score, reading, a whole bunch of things along those lines. And when you get to all of the papers, if you're interested in that, it turns out that we thought circulatory arrest was absolutely to be avoided. However, at around 8, it turned out the kids on low flow bypass were more likely to have ADHD. That made us rethink that. And then by the time the kids were 16, it didn't matter what you did in the OR. Just about the OR accounted for very little bit of what went on, and the same thing by the time these patients became adults. So our original focus of neuroprotection in the operating room and how you use bypass has shifted. And if you're interested in any of the papers, these will all be that you can see on YouTube, and you can see now why I'm not going into all of the papers from the circulatory arrest study, but they have really been very influential. The circulatory arrest study, this was the cost of the study, $24 million US, $25. And then you can see that we have many of the patients now still being followed. And then the last thing I want to talk about as I move forward is sort of where we're going to be going from here. As I look back on the time when I first started training, which was 85, I didn't realize how disruptive that was. There was no subspecialization. It was a real transformation. Cardiologists did septostomies and took care of EP and worked in the ICU. Cardiologists began to subspecialize. Nurses began to subspecialize into cardiac nurses. We're now starting to see subspecialization of many of the therapists who look after our kids, who just look after the cardiac kids, for example. And that's a good thing. What happened during those 2 decades? Neonates survived. Basically, all congenital heart disease is now amenable to something in the cath lab or surgery. We talked about subspecialization. We talked about multi-center collaboration. Now we're seeing multidisciplinary collaboration. Many things you all take for granted, but were relatively new concepts. The CardiacICU Society formed in 1999. The World Society of Pediatric Congenital Heart Surgery formed in 2001. DHCA has been virtually abandoned. The reduction of early term deliveries went away. It was very common early on that we would deliver the babies at 37 weeks so everybody would be ready. So it's good to see that some things change. But I got to be honest with you, there's not been many disruptive changes in cardiac surgery, cardiology, or ICU in the last 20 years. Very good incremental changes, but not the disruptive changes that we've seen in the 80s, 85 to 2005. This is a PubMed search I did a couple of days ago of congenital heart disease and brain. And you can see where that all started to take off. And again, congenital heart disease and neurodevelopment. And they all follow this trend that I've shown you on the timeline. The other thing is there was a very long time that the etiology was that they were blue, and then the etiology is that it was bypass. But I think we know now what we need to concentrate on. We need to concentrate on things we can do for the fetus, things we can do in our arena, in the ICU and the OR, and how we can support the baby and the family at home. These I would consider the 4 big disruptors that happened in the 80s and 90s. So where are we now? What are we going to try to do over the next series? So first of all, now that we have this current model, what should we do with it? Great formation of Neonatal Heart Society, Fetal Heart Society, PC4 and PAC3 inpatient databases. The Cardiac Networks United, NPCQIC has been fantastic. And these were all independent databases that now have been linked through Cardiac Networks United so that we can take a patient through and have their neurodevelopmental outcomes and hemodynamic outcomes followed. The first follow-up clinics in Boston, Philly, DC, and Milwaukee all started in the late 90s. The guidelines, which I'll show you in a second, the formation of our group, and the follow-up testing guidelines. And we're just at the beginning of interventional trials. We know that the factors affecting neurodevelopment are multiple, are sequential, and are cumulative and additive. And some are modifiable. This is a review I wrote with Dan Licht, and if you're interested in this, it goes through this model, which is what we're going to be talking about specifically, long length of stay. If I had to pick one thing that we should all focus on who work in the ICU, it is reducing length of stay. In every paper, in fact, be suspicious of a paper that doesn't have length of stay as a predictor of bad outcome or suboptimal outcome. It's a composite of how much pain you had, how much analgesia you received, whether your nutrition was okay, if you had low cardiac output and low blood flow to the brain, noise, lack of sleep, increasingly concerning data on plastic and metabolite exposure to all the endotracheal tubes, IV catheters, et cetera, altered cerebral blood flow, and family stress. All of these categories, I challenge you to look at these in your own unit, describe them at the beginning, do an interventional trial, do a pre-post trial in your own unit, make that a pilot study, work with colleagues in this format, and share your best practices. As they say in the NPCQIC, everybody teaches and everybody learns. So these are going to be, you can look at these on the website. They're just a few, some things that are ongoing to improve neurodevelopment in fetal interventions, when you should operate on babies with duct-dependent lesions, increasing data, as I mentioned, on plastics. You could take a screenshot of that one if you want, if you can't wait to read it and look at it on YouTube. Here's some things from our group. The guidelines for inpatient care and some really good models for providing individualized family-centered care. Amy Jo, the first author, and is on our panel today. The CNOC published the guidelines of what should be tested in 2020 on the right of your screen. These are the modified guidelines that are just published by the CNOC for updates in neuroprotection, et cetera. It's a great overall document. You can see here, these are the original guidelines that Brad wrote in 2012. I'm really excited about this study in Spain on the right-hand side there. If you haven't seen it, it's worth reading. It's a very comprehensive prospective longitudinal cohort looking at, it's the most comprehensive study I've seen to date. And then the single ventricle reconstruction trial, which is collaboration of multiple centers. So that's my challenge to you. The challenge is nothing more than a chance to make things better. I think we have a terrific opportunity as we communicate through this network and to build on what was done in the past. The Philadelphia Eagles, I haven't gotten into football yet, but I'm going to have to talk about the Philadelphia Eagles, who are having a playoff game against the Rams. Their expression that they're using this year is, to be great, you have to be surrounded by greatness. And it's all about collaboration. And when I look at the panel members that I'm looking at on my screen right now, who I've known for many, many years, and look at the 592 people that are on this webinar, which is just remarkable. With a Go Eagles chat, excellent. We have a great opportunity. We are surrounded by greatness, and I really look forward to seeing how the field moves forward. Thanks, everybody.
Thank you, Gil. Virtual clapping. I almost started playing the walk-off music when you mentioned the Eagles. I was like, No, thank you. That was a really, really nice introduction to this whole series. Thank you. Okay, so next up we have Dr. Bea Latal. She is a phenomenal psychologist at the University Children's Hospital Zurich. She's the co-director of the Child Development Center there. She's a prolific researcher and physician, as well as the chair of the Publications Committee in CNOC. Thank you.
Thank you so much for this really.
You muted yourself there.
I'm a developmental pediatrician. Hi, Gil. I'm basically, you said it all. So let's see what I can add to what you already said. I think we feel like you're just, the founder of this whole field, and you've encouraged us so much to continue working on it, to collaborate. I think that was one of your key messages. So I think I will pick up where you left and kind of maybe expand a little bit of what you said from my experience. And I will briefly go through some of the slides. And I'm also very impressed to see that number of participants almost hitting 600. I thought first I saw it wrongly, but it's really quite impressive. So hello from Switzerland. I want to open up the field, and we just talked about with Kelly and I about are the developmental problems that we see in children with congenital heart disease unique to congenital heart disease, or do we see similar patterns in other at-risk populations? And I think the beauty is that we all come from different fields, and as a developmental pediatrician, I did see children for many years before I kind of focused on children with congenital heart disease, children with other risks, with other difficulties. And among those are those with who were born extremely preterm, or those with hypoxic ischemic encephalopathy. Can you hear me? So good. So when I spent my postdoc time at UCSF in San Francisco, I focused on children with hypoxic ischemic encephalopathy, and then moved on to children with prematurity. And when you look at the prevalence for these two groups, very similar prevalence. The severe impairments vary a bit, but they're around 10 to 20, 30% when you look at cerebral palsy or severe hearing or visual impairments. But the most important part is mild to moderate neurodevelopmental difficulties are seen in a similar rate of about 50%. And now if you add the group of children with severe congenital heart disease, they have a very similar prevalence. The rate of severe impairments, depending on what study you take, and if you exclude those children with the congenital genetic disorder that contributes to a higher rate of severe impairment, what I want to point out is that the rate of mild to moderate neurodevelopmental disorders or disabilities is very similar to these two other groups. And I think it's very important to consider that when you think about how to do neurodevelopmental follow-up. You can do it within a cardiac neurodevelopmental follow-up program, but you could also incorporate these children into existing neurodevelopmental follow-up centers that already see children who have been born extremely preterm or with hypoxic ischemic encephalopathy. Now we'll come back to this comparison of the groups a little later. So the developmental domains, and Gil already has alluded to, can be grouped into kind of the main developmental domains. And I schematically show this in this overview. We can see motor difficulties that already occur pre-surgery, and I will go into that, in about 30 to 60%. We see language disorders that occur early on when language development occurs and can be seen as delayed. Behavioral problems occur. Many children have difficulties in behavior, such as hyperactivity, ADHD-like symptoms. And I will not go into detail in terms of learning difficulties in executive function, because we will hear more later from Kelly. The key message here is it's a high prevalence, low severity problem, often in combination. I think this is really important to note, that it's often not just motor difficulty, but the combination of these developmental problems. Kelly will go into the persistence of difficulties. And I would like to go back to the neonatal period or early neurodevelopmental abnormalities. Kathy Limperopoulos showed in a very important study almost 25, 26 years ago, that we already see muscular hypotonia, neurobehavioral regulation problems in a large percentage of children with complex congenital heart disease already prior, but also after surgery. So the idea that it's only because of the surgery, as Gil already said, is not true, that we already see neurobehavioral difficulties prior to surgery. And then when we look in the early infant period, we see a higher prevalence of definitely abnormal general movements, spontaneous movements in children with congenital heart disease compared to normal or normally developing children. This is a wonderful systematic review by Marie-Ève Bolduc with Marie Brossard in Canada, Montreal, and she showed that looking at different age groups, when you look at motor impairment, the rate of those with impairments below 1 standard deviation, you could call that mild to moderate impaired, actually increases somewhat and clearly does not go away. But the severe motor impairments decrease a little bit in prevalence when you look at this meta-analysis, each study being a triangle. But then the difficulty for the individual child is the prediction. So the difficulty really is that when you look at, and this is a very interesting study from Holland, at motor performance at 18 months, here on the left side, compared to 42 months in a group of children with congenital heart disease, and they grouped them in 3 groups, you could definitely see that, yes, if you were in an average group, you were most likely to stay in the average group. If you had significant delay, more than 2 standard deviations below, you could remain in that group, but you could also improve. And then the middle group, kind of at risk, which is a group of children with 1 standard deviation, it was basically open. You could go into average, you could remain at risk, or you could show delay. And I think it nicely shows that the prediction of neurodevelopmental outcome using early measures, whether it's motor or also cognitive assessments using the Bayley scales of infant development, is not very precise. And that's one of the reasons why we need to follow these children throughout their childhood into adolescence and adulthood. I want to point out one important aspect, and that's therapies and educational support. We looked at a group of children with congenital heart disease at 6 years of age, and we could show that 23% of these children with complex congenital heart disease had a type of therapy, either physical therapy or early intervention therapy during kindergarten or primary school. And the distribution of therapies, so one therapy or actually two therapies or even more therapies in combination was like this. And when we look at older children or another sample, this probably the rate of therapies increases to 50% in this very interesting study by Schillingford, where about half of all patients did receive some sort of educational support in the classroom or outside of the classroom. Now, I showed you another population at risk, the preterm children. We were able to compare two groups of at-risk populations, the congenital heart disease and those with prematurity. And you could see that 40% of very preterm patients had the therapy during kindergarten or primary school. Very similar distribution, but what is striking is the difference, despite, and I didn't show you this, despite exactly the same IQ or very similar IQ, so somewhat lowered IQ, the same rate of motor difficulties, the same rate of behavioral problems when assessed with the Strengths and Difficulties questionnaire. So what we can infer from this, at least in Switzerland, is that there is that children with congenital heart disease are disadvantaged in terms of the therapies they receive at school age, and that might be due to the higher awareness of developmental difficulties for children who were born prematurely compared to those with congenital heart disease. And I think we really need to work on improving this. I think I can go through this very quickly because Gil really nicely showed it, but when you look at mechanism, it's really complex. And as you said, it's not just the surgery. There are many factors that lead to the developmental problems we see arising or starting already prenatally. Genetic mutations clearly contribute, of course, to the heart lesion itself, but probably also affect the brain development. And then, of course, there's a direct link between altered perfusion and brain development. Inflammation may play a role during surgery. And then once children are discharged, they spend 18 years or longer with their family and in that family environment. And to no surprise, is this probably the most important factor affecting and modulating outcome. And recently, I've really become more convinced and saw so many studies that also looked at the importance of the placenta and the heart-placenta-brain connection. I'm not a specialist in this, but I think it's really important to look at that as a contributing factor. And of course, as Gil already mentioned, maternal stress during the pregnancy significantly contributes to brain development, intrauterine brain development. So one study that you already mentioned, Gil, I just want to go into that briefly, is the study by Bill Gaynor. We collected, and I was part of that study, 1,770 patient information, outcome information, where Bailey-2 was used. And in terms of risk factor, it was genetic comorbidity, complexity of CHD, birth weight, and gestational age, and male gender, all patient-specific factors that explain 27% of the variance in 1 year developmental outcome. The perioperative surgical factors were neonatal status, postoperative ECMO, longer length of hospital stay, as you already mentioned, but it was only 3% of the variance. So it's clearly not the surgery anymore. It's a lot patient-specific, but also parent socioeconomic status. I will skip that because I want to give Kelly enough time to talk. When we look at postnatal time, I want to emphasize the importance of socioeconomic status. So us and many other studies showed that when you look at parental education as an indicator of socioeconomic status, from the lowest to the highest, there are about 20 IQ points difference, just purely associated with low, high socioeconomic status. And importantly, we could show that there's an interaction, meaning the older the child becomes, so from 1 to 6 years, the effect of low or high socioeconomic status increases. So that children start off about half a standard deviation below the mean for IQ, and then children from a higher socioeconomic background can catch up to a normal degree, while those with the lowest socioeconomic status actually decrease, and that's in Switzerland. So I think that means a lot. And what is the driver of this? One study by Alexandra Bonthron in London with Serena Council could very nicely show that using a simple questionnaire, the Cognitively Stimulating Parental Scale score, ranging from 15 to 45, showed very nicely that the more stimulating the family environment was, so the more books there were, the more parents read to the children, the more play was done, the higher the cognitive composite score was. And this was also found, for executive function at an older age. And I want to finish by emphasizing the enormous importance of maternal or parental mental health. Melanie Ehrler very nicely using this latent growth analysis showed that there are actually two groups of here in this case mothers. One group who shows normal mental health related quality of life. They start off poorly at discharge of their child, being very stressed, having poor quality of life, but they catch up and they remain at a normal rate. And then there's at a normal level. And then there's a group of mothers who cannot catch up and remain lower with a low maternal mental health. And the low maternal mental health was associated with poor social support, but also was predictive of behavioral difficulties at 10 years of their child. So to sum quickly, I could hopefully show you that children with congenital heart disease have a higher risk of impairments in development in all developmental domains. They do receive fewer therapies, despite having similar outcomes compared to preterms. We have a very good sense of the risk factors, but I think we cannot emphasize enough the environmental factors and parental mental health. And I think maybe at the end we can discuss what this means for us in terms of intervention. Thank you very much for your attention.
Thank you, Bea. That was very enlightening. I learned a lot as I was listening to you, so thank you. All right, and our last...
Chetna, before you introduce the next speaker, I just want to mention to the many people that are here, which is great. So I see a bunch of questions coming through on the chat. Please put them through the Q&A box, and I'd ask the panelists to keep an eye on the Q&A box for your area of specialty where you can answer that question the best.
Thanks, Gil. All right, so next up, and our last speaker for this morning is a good friend, Dr. Kelly Wolf, a neuropsychologist at the Children's Hospital of Colorado. She focuses on care and research of the neuropsychologic sequelae of children with congenital heart disease, and she is the immediate past chair of CNOC.
Thank you so much to Chetna and Gil for having me. It's an honor to be here, and I will do my best to follow those two incredible presentations from Gil and Bea. All right, can you guys see the correct slides? Okay, that look right. Thank you so much. So I am tasked with wrapping up this first installment of this incredible webinar series by talking about neuropsychological outcomes through the rest of the lifespan. So we've heard from Gil about historical changes in the field that led to us even being able to do this research and to talk about these long-term outcomes. and from Bea about especially some of the etiologies and risk factors in brain and neurodevelopment early on in childhood. And so I will build on that through school age, and I took the liberty of extending this through adolescence and into adulthood, because the exciting thing is that now we get to talk about adult outcomes in our critical CHD population. So building off of where Bea left off, an overall summary of studies about neurodevelopmental trajectories across school age is that while overall IQ may be in the low normal range, there are difficulties across neurodevelopmental domains. These include visual, spatial, and visual motor challenges, memory difficulties, symptoms of inattention and impulsivity, particularly attention problems and ADHD, executive functioning challenges, and executive functioning includes skills like planning, problem solving, and organizing. Neuropsychologists sometimes talk about executive functioning as being the CEO of the brain, involved in recruiting all of the other skills in the brain in order to accomplish a task. Academic achievement is thought to be affected downstream from these cognitive challenges, because if you're struggling with handwriting and memory and paying attention, that will affect reading, writing, and math over time. We also know that our children with CHD tend to have higher rates of mental health challenges, especially anxiety, and sometimes difficulties with social relatedness with peers as well. These difficulties are exemplified and described in this table published in Cindy Ortna's paper, which was a reprint from Dr. Karatanova's paper from 2016, kind of summarizing the domains that the literature has shown so far to be affected in critical CHD. But sometimes it can be overwhelming, even as a neuropsychologist, to think about all of these different cognitive domains and how much each are affected. And so from the research, as well as hearing from the lived experience of individuals with CHD, I often like to talk about the 4 A's as being some of the areas where we see the most difficulties in neurodevelopment in childhood and adolescence. These include attention and executive functioning. So again, kind of that ADHD profile, planning, organizing, and problem solving. Academics, reading, writing, and especially math. Adaptive functioning, which is an indication of someone's ability to complete tasks of daily life independently, kind of being able to navigate the community and transition to adulthood and gain some independence. And then finally, anxiety, which includes medical trauma and post-traumatic stress from medical cares. These difficulties are exemplified in one of the studies that has been published with a larger sample of children with Fontan circulation. So this is one of the larger clinical samples, 93 children with Fontan circulation, ages 5 to 18. About 30% of this sample was diagnosed with ADHD formally. About 20% were diagnosed with a specific learning disorder in reading and or math. 16% were diagnosed with anxiety. 10% were diagnosed with intellectual disability, and the prevalence of intellectual disability in the general population is about 2 to 3% for reference, and 9% were diagnosed with depression. And so I'll kind of show how this sample exemplifies some of the literature that was summarized earlier in this presentation. You can see with this first yellow box that the overall IQ and those t-tests are compared to the normative population, to the reference population. Overall IQ is in the low normal range, with the biggest effect sizes in processing speed and overall full scale IQ. Attention and executive functioning shows some of the largest effect sizes, and this is across formal standardized testing of executive functioning, as well as standardized ratings of executive functioning behavior in day-to-day life. So across both of those domains, we see mostly large effect sizes, especially in the areas of planning and sustained attention over time. Academics are also affected, and you can see that the largest effect size was in math, which was the lowest score out of the 3 academic domains in this group. Adaptive functioning showed the greatest effect sizes, so even above and beyond cognitive challenges, this group was struggling to be as independent as their peers in day-to-day life. Especially in conceptual tasks. So that's functional academics, applying academics in day-to-day life, communication skills, and practical daily living skills. And finally, important to note that rates of anxiety and depression symptoms were higher in this population compared to the general population as well. This finding is borne out in samples across the globe as well. So in a meta-analysis published in the European Journal of Psychiatry, the authors found a higher 1.35, so about a 35% increased risk for diagnosis of autism spectrum disorder for children with congenital heart disease, as well as a 3-fold increased risk for a diagnosis of ADHD. Similarly, in a population-based study in Taiwan, the authors found an almost 2-fold increase in risk for diagnosis of autism and a 2.5 times increased risk for a diagnosis of ADHD for children with CHD, regardless of severity level. When we go behind the scenes and try to think about why we see these long-term neurodevelopmental challenges, I think the literature really extends some of the studies that Bea presented, looking at differences in brain structure and functioning. And so one of the first studies to look at childhood brain volumes and development was by Dr. von Rijn in 2014, looking at 39 teens with congenital heart disease who had surgery with bypass during the first 5 years of life, from 11 to 16 years old. And the big takeaway here is that across these different gray and white matter structures, brain volume is still smaller than healthy controls across areas. The biggest differences were seen in white matter volume, which with an 8.5% volume reduction, and in the hippocampus, which is the memory center of the brain, as well as the corpus callosum, which is a bundle of fibers that connects the left and the right side of the brain and allows for efficient communication between the two halves of the brain. In this study, total brain volume predicted overall IQ for the congenital heart disease group, but not in the control group. Again, helping to tie that link between these differences in brain structure and development over time and the neurobehavioral and neurodevelopmental outcomes that we see. A great deal of this work has been done by Bea as well, and Dr. Erler, her colleague in Zurich, who is now in London. This study looked at 47 adolescents in the same time frame as the von Rijn study with congenital heart disease compared to controls, and found widespread reductions in white matter integrity in the CHD group, particularly in the frontal lobe, in the forceps minor, and that this was associated with poorer working memory in both groups. So helping to kind of define which areas of the brain in which areas is white matter integrity differences really linking with some of those neurobehavioral and neuropsychological outcomes. Caitlin Rollins from Boston had a similar study with adolescents with transposition of the great arteries, building on some of Gil's description of the Boston circulatory arrest study. And this study showed that white matter differences in the in different areas of the brain were related to neuropsychological outcomes. So white matter differences in the left parietal lobe were related to lower math achievement and inattention and hyperactivity symptoms in this group. White matter differences in the right precentral cortex were associated with increased inattention and hyperactivity and more difficulties with executive functioning. White matter differences in the right frontal lobe was associated with decreased visual spatial skills. And white matter differences in the internal capsule, the posterior limb specifically, were associated with difficulties in memory. And on my schematic of the brain down here, which is more colorful than a real brain, of course, you can see the functions of those areas and kind of why that makes sense when we're tying together, again, the neuroanatomy with the neurobehavioral phenotype of congenital heart disease. And so I'd like to take a step back and zoom out and talk about congenital heart disease as a lifespan condition. When we look at adults with congenital heart disease, which, as Gil nicely laid out, is an emerging field simply because we are now seeing more and more people with CHD survive to adulthood, we overall see a continuation of the neuropsychological profile that has been described from childhood and adolescence. But the impact of executive functioning difficulties becomes more pronounced because we expect more executive functioning, independence, planning, problem solving, and organizing for adults in our communities. And the impact of parents and teachers and structures such as schools becomes lessened. So those supports change over time. and the pattern of generally poorer neurocognitive outcomes or higher risk, we should say, in those with more complex CHD diagnoses also continues into adulthood. So in one meta-analysis that has been put out, again, in adults with CHD, overall IQ is broadly comparable to controls, but difficulty in working memory, processing speed, attention, motor skills, nonverbal reasoning, executive functioning, verbal memory, math, and reading persists with about moderate effect sizes across domains. Again, from Bea and Melanie Earlier's work, a study looking at 45 adults with congenital heart disease and matched controls showed widespread bilateral reduced white matter integrity. And you can see that the white matter integrity was really well correlated with the severity of congenital heart disease in the graph to the right. And FA is fractional anisotropy, which is a measure of white matter integrity, and higher is better. Additionally, this study nicely looked at executive functioning skills by looking at doing a number of different tests and then creating a composite score of executive functioning, looking at inhibition, cognitive flexibility, working memory, verbal and nonverbal fluency, and problem solving. And Bea and Melanie found that executive functioning scores were associated with reduced white matter integrity, specifically in the left superior corona radiata, which is kind of a fan of white matter pathways in the cortex, as well as the corticospinal tract, which is involved in motor as well as cognition. I also want to mention that there's some emerging research suggesting that adults with CHD may have a higher risk for earlier onset cognitive impairment, dementia as well, although we are still learning more about this. Some of the early work comes out of a population registry study from Denmark, looking at 10,000 individuals with all types of congenital heart disease compared to controls, and found a more pronounced risk for especially earlier onset cognitive impairment, especially for those with severe congenital heart disease. Though again, more research is needed to understand this phenotype and whether it will continue to be seen over time, given new advances in medical care over the decades. I always go back to this incredible schematic from Ariane Morelli, published in 2016, as I kind of wrap up to summarize the brain across the lifespan in congenital heart disease. And so as we have heard today, congenital heart disease in the fetus and newborn period causes hypoxia ischemia, epigenetic and genetic factors interact to produce injury as well as dysmaturation in the perinatal brain. This is continued in infancy and childhood, where we see cyanosis, abnormal hemodynamics, punctate foci of injury related to cardiopulmonary bypass, and CHD complexity impacting white matter development over time. And then as we learn more about the risks for acquired heart disease, such as AFib and coronary artery disease in the adults with CHD, and how those, which all carry risk for cognitive challenges in adults without CHD, may impact the vulnerable developing brain for people with congenital heart disease. I want to end with a few points about social determinants of health and mental health. The first is that social determinants of health can impact quality of life, transition, and health outcomes, as well as neurodevelopmental outcomes for people with CHD at all ages. And the schematic from Anitha John's paper in 2022 really emphasizes how the neurodevelopmental challenges for people with CHD can result in reduced education, access to healthcare, income, and in some countries, insurance coverage over time. And from this American Heart Association scientific statement in 2022, led by Adrian Kovacs, emphasizing that neurocognitive and psychosocial considerations for people with CHD are really intertwined across the lifespan and come into play at different life stages. And I really want to to highlight the impact of medical trauma and traumatic healthcare experiences, which the more I hear from individuals with lived experience of congenital heart disease, the more it is really striking me how little we know and have studied about the prevalence, the incidence, the predictors of medical trauma, and most importantly, what we can do early to mitigate those impacts. So to summarize, I hope that I and we, my fellow panelists, have convinced you that congenital heart disease is a lifespan condition. neurodevelopmental brain anomalies and neurobehavioral differences interact with cumulative neurological injury over time to impact quality of life and outcomes across the lifespan. And importantly, as we kick off this series on neuroprotection, cardiac neurodevelopmental care plays an absolutely crucial role in optimizing outcomes from the prenatal period through older adulthood. And I hope that this helps to set the context for the importance of the work that we'll be talking about in this webinar series, that neuroprotection early on can change the outcome across the trajectory of the lifespan. I'd be happy to take any questions. Thank you so much.
Thank you, Kelly. So thank you all, and thank you for all the questions that are coming in. I think we're slowly trying to get them all answered. But the purpose of this introductory webinar was really to set the stage, was to show that this is neurodevelopmental outcomes is a very common and potentially one of the most impactful morbidities that these children and families incur. I know we've shared a lot of data today, and a lot of the questions are, okay, we know all this, what can we do? So that's where we all need to get together, and we're excited about this collaboration so that we can also work together, research, share data, and learn from one another. And so rest of the series, we're going to be focusing on different aspects of everything we've talked about. The next one in February is actually going to be focusing on intra-op neuroprotection and neuromonitoring, because as many have commented, of course, going on to bypass and getting a very long surgery is may affect your impacts. And so we'll be talking about that, as well as the pre and post-op neuroimaging and neuromonitoring. What can we be doing to try to predict the kids that may have issues and then catch issues quickly after surgery? And so definitely log in. We'll be going into more detail into a lot of what we talked about today over the next 6 months or so. Grace, I'll hand it back over to you.
Thank you so much, Evelyn. Thank you so much for all the speakers. It was a fantastic introduction. And I think the most important thing is that everybody, as we can see, the amount of people who is already watching this webinar wants to know more. Everybody started to think about it, to understand how important it is, not only this patient to survive the ICU, not this patient go back home, but how this patient is going to behave and his quality of life. So thank you all for putting this fantastic series together, and then I think Gail can conduct the Q&A.
Grace, do you typically do verbal questions now, or is it all still in the Q&A?
So usually what we do is that if someone in the panel has something to add, and from everything that was discussed, or if they saw any questions on the Q&A that was answered already, but they found interesting to share with the audience, please do so, and then we can take a look in some Q&A, the most interesting ones to answer live.
Perfect. And we are over the hour. So anyone that needs to leave, definitely we want to respect your time, but anyone that can stay on, we'll definitely keep answering questions for a little bit.
Some great questions and answers from the panel in the Q&A. Do these, Grace, I should know this, but I don't. Does this get saved on the YouTube as well? The Q&A?
Yes, not on the YouTube, but we can have a transcript of that.
Yeah, I think we should do that. That's why I've told most people to take it from the chat to the Q&A.
Yeah.
But they were coming in so fast, it was hard for me to keep
read
up.
everything. Yes.
It's so great that everybody's so interested, and it's been fantastic. There's been a stream of them that I'll mention to the people that are still on. We all sort of want cutoff numbers, like how long is too long of bypass, how many years is too long to be blue, et cetera, et cetera. And it's tempting, but it's always impossible to take a continuous variable like time or age or anything and put a cutoff in there. And like if you pick 13, is 12 fine and 14 bad? No, of course not. So we're all looking for inflection points. The inflection points are modified by other things. And I think what we've learned is, although there are no simple answers to complex questions, and these are complex questions, and it's going to take all of us. It's going to take 2,000 patients in a registry to tease this stuff out. The single centers are hypothesis generating, probably not hypothesis testing. And the hypothesis testing can happen through the group.
Anyone in the panel has something to add to everything that was said, or wants to answer one of the questions from the Q&A that you found interesting?
I think one of the themes that maybe it's from some of our parent attendees, there was a lot of questions about how, as a CHD parent, can we help to advocate for this or support other families? And I'm wondering what the panel thinks about this, because my dream, if, you think about the oncology world, they have like Alex Lemonade Stand that funds millions and millions of dollars of research. And I really think that, we've talked a lot for probably at least the last decade about the importance of family-centered developmental care. But it's challenging to get that work funded because it's not like the sexy new drug or the curative, like you're curing congenital heart disease, but we could be, curing long-term developmental care outcomes. And it's very hard to get funders, at least in my experience, to really buy into that because family-centered care isn't seen as innovative or novel. And, I think that if we could get a grassroots efforts of families they're happening already, but getting them to the level of that nationally recognized Alex Lemonade Stand would be a dream of mine, I think, because I think it's the parents' voices and the patients' voices that are the most powerful in this world. Gil, you had your hand up. I don't know.
Yeah, no, it was
to that or
fat thumbs. It's, the usual things.
But be empowered, those of you out there that are here. Go ahead.
Yeah, I agree. Hi, Amy. I fully agree with you. Really connecting with parents as we all do, but I think even connecting with them in a more kind of formal way, having them being part of hospital CEO, kind of really officially including parents in decision making in the hospital or also in outpatient centers, in strategy decisions, I think is really important. And then, of course, collaborating with them in terms of getting funding. I think many funding agencies require to have like parents or patients to be included in the process of developing the research questions or developing programs. So I think that will help a lot. I wanted to address one question that I thought was important in terms of assessment pre and post-operatively, neurodevelopmental assessment. I think there was a question about that. I think it's really important to have experts, whether that's developmental pediatricians or physical therapists or nurse practitioners, involved already pre-operatively also in the assessment of the neuro behavioral status, because it's important to have like a baseline and then counsel prior to the surgery, and then also go back post operatively, because sometimes children were really good pre-operatively and not as good post-operatively, and then have early intervention or specific therapies involved. And there's been a study that showed that if you have early developmental assessment prior to discharge, neurodevelopmental follow-up is higher. So the likelihood of parents to come back for follow-up, which is so important, increases if you've had some kind of neurodevelopmental inpatient assessment or counseling or rounds. Or Karen Goldberg, I think, showed that.
I have a question for the panel. This series is focused on newborns and infants, and I'm curious as to how soon is too soon to start discussing our concern about neurodevelopmental outcomes for parents of newborns and infants.
Personally, I would say I don't see these families pre-op or prenatally typically, but I think it's really important to, parents get a lot of information, but I think it's important to introduce the concept at least prenatally. Like, I don't think my heart goes out to the families who their expectation is that once the heart is fixed, everything is better. Because I don't think that's fair for them. I think we should be bringing it up earlier and letting them know that we don't know what degree of neurodevelopmental delay they may have, but it is a known risk factor, and these are the things that we can do to address it. Because that also will help them plan postnatally for where they may want to deliver, where they may want to follow up, how often they're going to be following up, just things like that.
wanted to ask Dr. Sarah Schlatter to answer that. She's working on that. But I do want to say what's interesting is what I know my fetal colleagues, neurology colleagues, say in the prenatal visit. And when I meet the family in the ICU, what they actually remember. I don't know if that's actually been studied, but I know that when I speak to people, that, yeah, I met that, I'm not so sure. It would be worthwhile, I think, sort of getting an idea for retention of that information. But anyway, Sarah, you've been working with a lot of the families, and they get information overload. What are your thoughts on when? How soon is there a too soon?
You know, the feedback that I've gotten from, so I'm a neurologist, and I often work with families with CHD, even in the prenatal period, and we will have a consult and just talk about the brain and just talk about development and what to expect. And as part of that consult, we go through a lot of stuff. I think it can be a little overwhelming. We talk about long-term developmental outcomes and what those ranges might look like. But importantly, we also discuss what we're going to do about it. We talk about the supports we have in place. We talk about, you know, the neurodevelopmental program that is in place for these kids. We talk about how we monitor their babies' brains in the cardiac ICU when they're in that really critical period. And I think importantly, we also talk about what parents can do, particularly in that critical ICU period, to try to empower them to feel that parental role, which I think is often lacking and can often have a significant impact on the overall mental health and stress of the families in the ICU. And while you were correct, Gil, that I think no family with CHD is going to remember every detail of every consult, even when it comes to the heart, and when they've seen the cardiologist multiple times, you know, many of them aren't going to be able to express exactly what's going on with the anatomy or with the heart. They're not going to be able to remember every detail, but I will tell you that when I go back and I see those babies in the CICU, the families remember, you are the only person who told me what I could do for my baby in the CICU. And so I think for all of us, regardless of what our touch point is for the families, talking about this prenatally, often I'm seeing families around the 3rd trimester. So after they've had a chance to kind of process a little bit that their baby, often after they've had a chance to process this. But for all of us, regardless of what our specialty is, you know, saying, hey, here's what you can do for your baby, and empowering the families. Those are the things that they remember, and I think that empower them to feel important in their baby's care. It's my 2 cents for what that's worth.
I'd like to add, Sarah, I think you're 100% right. And I understand why the parents, sometimes they get confused, because imagine you have hypoplastic heart syndrome that goes for the neuro, becomes so sick, comes back on open chest, full of drains. Not even us, the providers, you want to touch him because you're scared, or the patient is unstable. And the moment exactly when that family is able to do something, the moment that family is able to start to play with their newborn, start to touch, start to give some care, they don't know. They don't know. Everybody's scared. And so it's us as providers that need to tell them, now you can bring some toys to the room. Now you can sing to your baby. Please talk to your baby, and help us to change the diaper, because they don't know when it's this time when they can really start to do something.
So true. No, thank you for saying it so eloquently, both of you. Parental empowerment is really, I think, how we can start making a dent and moving forward.
Chetna, can I just add, I think that I completely agree with both what Grace and Sarah said. And I think parental empowerment and giving them some of their role is essential. I think that this is not something that happens one day or at one point or by one person. It's something that is like a culture that permeates our team. And for it to be effective, everybody has to speak that language, and everybody has to have that same mentality that's sort of weaved into our practice. So it's not one decision or one conversation. It's like something that we all bring, whether it's a PT or a speech therapist, a nurse, a physician. I think, you know, reminding parents what they can do for their baby is important to come from everybody at all different touch points.
Couldn't have said it better. That's, yeah, every person on the team is so important, and everybody cares so much about this. I think it's so critical.
Yeah.
And that it happens multiple times.
Yes.
Not
Yeah.
one touch point, right? Not just prenatally, not just one time in the ICU, that we're all constantly reminding, because it's too much for anybody. If you only hear something once, none of us are going to remember it, right?
Right.
It's interesting. The first time I saw skin-to-skin care in our unit, early on in that whole process, I don't know who was more excited, me or the mom, but I also realized that the mom was terrified. And I think it is, it's tubes coming out. I mean, it wasn't like I'm holding my baby ready to go home. It was, the nurses were great and got the baby to do that. I think it's also good to validate that mixed emotion of scared, maybe even terror, I don't know, but validate it. I know it's scary, but it's so important and good for you. You're a great mom. Look what you're doing. And you can do this as much as you want. I think we forget sometimes how scary all that is, because we get so excited when we see how well a baby is doing. And yes, that's true, but that fear is real. And parents have told me that multiple times when I see them in clinic afterwards, and to validate that when we see our parents.
Not always just the parents too, right? This takes a lot of education and support for the staff members to engage in all these practices. This is not easy. And so I think, while yes, of course, all this support for families, we also need to support that person at the bedside and their continued education, so that they can feel comfortable engaging with families, supporting practices like skin to skin with a very fragile infant. And that's an ongoing process too.
I'm sure that we could go on and on and on forever.
Yeah.
I'm going to suggest we put a hard stop on one more question. And then we will have another. You want to give a good perk for the next one, Chetna, before we go on?
Yeah, let me pull up the flyer so we have it up. All right. All right, Grace, can you see the flyer?
Yes.
Okay, great. Yeah, so the next one is going to be February 14th during Heart Month on Heart Day, and we'll be focusing on intraoperative neuroprotection, and we'll actually be talking about neuroimaging and neuromonitoring in the pre and post-op period as well. And so this will, we'll have speakers representing neurology that work in the critical care unit, where you may have some surgeons there as well to give their 2 cents, some anesthesiologists. And so I think it'll be a really good session to get some good discussion going.
We'll cut that one out of the webinar, their 2 cents. They're most highly important.
But it was a fantastic webinar, and thank you all for giving your expertise, and we could see that everybody is very interested, and this is so important for our babies. So see you guys in a month or so. Bye-bye.
Anna Jaworski, I'm going to just give one shout out. Thanks for joining us.
Thank you, guys.
Thanks, everyone.
Thank you all.
Thank you.
Great.